it passes through 4 phases. The first phase is a mixing phase, which starts from like 50 seconds and take up to 2 minutes. The do phase can take from 2 to 3 minutes. The working phase from 5 to 8 minutes, and the sitting phase from 8 to 10 minutes. The second one is the other material we can use also in our practice is ultra high molecular weight polyethylene. It is a polymer of ethylene with high molecular weight. It is metal. It's usually used as a metal on poly, which has high success rates in the bearing surface in arthroplasty, used for the acetabular cups and tibial inserts. The manufacturing of the polyethylene pass through multiple steps, starting with ethylene oxide polymerization in low temperature and low pressure environment to reduce the ultra high molecular weight polyethylene powder. Then compression by ram bar extrusion, which like a machine was putting the powder and to give like rods of the polyethylene, or by direct compression molds. It's have a specific mold to give a specific shapes for the polyethylene, which is better but it's expensive. Then it passes through the sterilization of the polyethylene. It's sterilized by the ethylene oxide gas or gamma irradiation in a vacuum, because if to avoid oxidation in the air, so it should be done in a vacuum area. And this will lead to more cross-linking and improve the resistance of wear. And the last thing is addition of vitamin E, which is an antioxidant to limit the oxidation of the polyethylene. The advantages and disadvantages of the polyethylene. The advantage is it's tough and ductile, resistant to wear. That's why it's mostly used as for the surface material. The disadvantages of the polyethylene, it's susceptible to abrasion. The polyethylene wear debris lead to osteolysis and aseptic loosening. It's not wettable. It's rough and have high friction. And sometimes it can lead to catastrophic wear of the polyethylene, where there is delamination of the polyethylene with significant loss of the mechanical toughness due to fatigue cracking, like we can see in this picture, where the polyethylene was broken, and we can see it in the X-ray. There is a collapse of the head into the acetabular cup, and after removing of the surgery, we can see the catastrophic wear that happened at the polyethylene. So in summary, after all of this, we need to be aware about this biomaterial we use. So adequate knowledge of implant materials is essential to make the best choice of implant selection for the patients. Advances in the medical engineering will go a long way in aiding the orthopedic surgery. Thank you.
Thank you so much, Dr. Muhammad, for this very interesting talk about a very important topic, which is the biomaterials. Thank you so much for being with us.
Thank you.
We have 2 questions. First question: can we reuse the extracted or removed plates and screws and chance pins from healthy patients to another patient with no visible damage?
No, I don't think we can use it again, because as I told, there is cycles of stresses happen for the plate, so it can be easily broken in the way we add it to the new patient, below, even if below its tensile strength, because it has already fatigue, and fatigue failure can happen easily if we add it for another patient.
Yes, of course. Even if it looks normal, but it's not normal, of course. Another question, the second question from Dr. Gamal Qasim: can the biomaterials withstand any wear when using in lower limb fractures? Any weight, sorry, when using for lower limb fractures?
It depends. So if we use a metal, they can withstand the stresses and the weight of the patient, but not all. Like polyethylene cannot withstand the weight. And it depends upon the metal we use, as I said. So usually we use the stainless steel, which has the similar Young's modulus to the bone, so it will help the union of the bone. But if you use like a stainless steel in the nails, it will leads to stress shielding around the metal, and will delay the healing of the bone. So it depends upon the method of fixation you use. If in intramedullary fixation, usually we use use titanium. If we use a surface fixation, usually we use the stainless steel, which is more stiff and can resist the stresses when we use a surface fixation.
Yeah. Thank you so much, Dr. Muhammad, for being with us. We have no other questions. Thank you so much. And we will move to the next speaker, Dr. Abdurrahman Komi from UK, will speak about the principles of internal fixation. Dr. Abdurrahman, you are with us?
Can you hear me?
Yeah, we can hear you.
All right, thank you. So just I'll share my screen.
Please.
Here we go. Hello. For my session today, first things first, I'd like to thank everyone to attend all of this. Can you see my screen right now?
No, I don't see it. No.
No.
No. Yes, it's something to be shared. Yeah.
So first things first, I'd like to thank everyone to attend this session. It's my first time to be on the other end of this kind of sessions. I usually one of the audience, but tonight I have to present this presentation about the internal fixation of bone. So I spend a lot of time really to think how to make these things in a very simple way, because it takes a lot of time to think about it and to put it in a very simple way, to be ready in your mind if you want to think about it, to make any kind of decisions. It takes me some time. So I used to work for two bosses. One of them usually have a very high threshold for fixation, for fracture acceptance. So we like to operate, like to let most of the fracture to be conservatively managed. And yeah, he loves soft tissue, so he don't like to deal with it in a very inappropriate way. So he like to deal with it very respectfully, the other one, he doesn't like reaming and he doesn't like soft tissue. So it always trick me, like what is the most possible way to make any simple way to think about things and how to put any basics inside my mind. So if I need to think about fixing fracture, what should I think about? So this is my hospital. I work in Gloucester Royal Hospital, TNO. Yeah. So first things first, bone is dynamic tissue, which is constantly remodeling. So bone is a balance between resorption and deposition. And these two processes are achieved by the balance between osteoclast and osteoblast. So when we want to think about bone, it looks tough and it looks very strong tissue. However, you can easily disturb this balanced atmosphere, and it will lead to serious complications. So we need to know how to deal with the bone cells and how to make a harmony with it to reach our ideal goal, which is fixation and union. So if we want to talk about types of fractures, we can classify fractures according to their locations or the severity, or if it is open or closed fracture, it is comminuted or a simple fracture. Also, we need to think about what is the most suitable way to fix this kind of fracture to reach the target, which is a primary bone healing. Which is not very easy in most of times. So we tend to heal, we tend to use ways to fix fractures to to achieve the secondary bone healing. And the primary bone healing, usually that's the ultimate goal. It's a bone healing without any callus and without any stress on the bone, which we will talk about it later on. And the treatment options, we usually depend on the kind of fracture and if we what is the outcome we need to do for this patient, if we need him to move faster or we need him to wait until for a second stage of fixation, 2 stages fixation, or whatever. So if we come to the principles of internal fixation, so we need to stabilize the fracture to achieve the primary bone healing and to restore the alignment and length and rotation. We like to do this in the least invasive way as much as possible, and of course to achieve to avoid any fracture fatigue on the implant or stress fatigue on the implants we're using. So the stability we are achieving, it's a pyramid or a spectrum. So there is a lot of types for stability. The dream and the ultimate one is the absolute stability. So the first goal we need to search for or try to establish is absolute stability. And this is usually by interfragmentary compression and lag screws. So if we are not in a position allowing us to achieve the absolute stability, so we can accept the relative stability through operative by plates or interlocking nails or external fixators. And of course, the blasters and tractions are the relative conservative stability. The plates, the metal plates for internal fixation of fractures have been used for more than 100 years. Although initial shortcomings such as corrosions and sufficient strength have been overcome, more recent designs have not solved all the problems. So further research is needed to develop a plate that accelerates fracture healing, which we all hope and which we all look for, and not interfering with bone physiology. The introduction of rigid plates had by far the greatest impact of plate fixation of fractures. However, it leads to cortical process and delayed bridging and refracture after plate removal. So these unwanted effects were said to be caused by bone plate contact interfering with cortical perfusion. So how this plate's working usually, it's working by to achieve two mechanical functions, by transmitting the forces by protecting the fracture or bypassing it, and hold the fracture in a proper alignment. These two functions depends on the plate profile and the material of the plate and the bone quality and the fracture pattern, of course. So it's the more comminuted, the harder for the blade to fix the fracture. And the stability is the sum of relationship between blade factors and the fracture factors. Just bear with me. So when we are talking about the stability of the fracture or the stress that happen, so the absolute stability create a low strain environment conducive leading to direct bone healing to achieve the primary bone healing. The relative stability, it's causing some kind of stress between, I think, 4% to 10% of this can lead to relative stability. And if the stress more than 10%, so this will lead to a high gap elongation and less excess tissue compliance, which can lead to cell rupture and cessation of healing. The blade influence of screw placement relative to the fracture site, the working length. So the working length, as we can see here, is the distance between the innermost screws related to the fracture site. So the blade stress within the short working length is higher and the plate stress within the longer working length is lower. Also, we should use the length of the plate wisely to achieve the effective usage of this plate. So as you can see in plate A, the effective usage of plate length is very long and the plate B is shorter. So the longer, of course, the better. And the effect of plate length of screw loading. So for giving the amount of bending moment for a longer blade produce markedly less pull-out force than a short blade due to an improvement of the working leverage of the screws. Also, if you're going to use a blade, we need to check that to achieve the working length of the fracture, and it depends on the type of the bone and the mode of fixation you are using when you use a blade, and also the type of the fracture. So in normal bone, the working length of monocortical screw is enough, but in osteoporotic bone, we need to fix the bicortex or the two cortexes of near and far cortex, because there is a very high risk for the bone thread to wear out and causing instability of the fixation you're trying to achieve. So as you can see, there is a lot of type of plates, but here we are going to talk about how to use these plates to achieve the fixation you need. So there is a bridging way, or buttressing, or tension band, or neutralization, and compression and locking also for brittle bones. The buttress plate, as we can see here, the buttress plate is a form of anti-glide technique for the peri-articular fractures. So we use this plate just to push the proximal part of the fracture, just to keep it still. Like if we can do it with someone who can put his finger on the fracture just to push it until it heals. So we use the blade to achieve this target. And we can use also a supplement leg screw to avoid the metaphyseal shear and in the metaphyseal regions. The bridging blade, this is a sort of relative stability. We use the bridging blade for the comminuted fracture. So this will help us to restore the alignment and restore the rotation and restore the height as much as possible. And also it's respecting the biology of bone, because it is not causing that much damage to the broken area already. The neutralization plate provide additional support for leg screws, but doesn't apply any kind of compression themselves. So you need to use it just to help the leg screw to achieve the absolute stability, to achieve the primary bone healing. And eventually, last thing is the tension band. So we can use the blade to as a tension band in theory, such as in the fracture femur, but due to the high load on the fracture, we are not using this very often. But still, theoretically, we can do this. And this is like a summary for all this kind of fixations we talked about. So the future for the blade fixation, first thing is the biodegradable blades. I think there is a lot of trials right now to create a blade that can cause a fixation we want to do, and on the same time it can dissolve like a vicryl thread, just to reduce the load of infection and reduce a lot of complication coming from the need to remove the blades later on. Also, I think that 3D printing is very popular nowadays to produce plates specific for patient's anatomy. And of course, we can enhance use enhanced imaging techniques to pre-operative planning, so we can choose the plate pre-operatively, so as we can do in X-ray programs, just to choose how many holes we are going to use and what the profile of the plate we use to fix this fracture. The screws here, I don't like to talk about it that much because it's very basic concept. So there is a lot of types, and we can classify the screws into multiple types, such as cortical, cancellous, locking and unlocking, fully threaded and partially threaded. But this all types, it's all related to you choose it when you decide to choose which kind of fixation you are going to achieve. Yeah, and the last thing we are going to talk about today is the intramedullary nail. And funny to know that the first intramedullary device was described in the 16th century by Bernardo de Sahagún. He documented Aztec physician in Mexico using solid wooden pigs for the treatment of non-union. And in 1875, Haynes introduced the use of ivory interlocking nail for femoral shaft fractures in Germany, and the use of ivory later on become a material of choice for interlocking nail until the World War II, which changed to be metal fixation. And from World War I, 1910, also witnessed the development of interlocking nails and pins made from ivory, but metals win this war, and now we are all using metal right now. The intramedullary nail, I think it may be one of the greatest things, because one of my bosses told me that when he was a resident, you can walk in the ward and find 50 patients lying on beds with a traction because of the femoral fracture. And this long lion bed caused a lot of problems, as we all know. So he think that the interlocking nails may be the most helpful invention on the treatment on the world of orthopedics. We can use this interlocking nail to achieve the alignment and the length and the rotational stability. And reaming, this will help us to increase the diameter of the medulla that we are using, and the greater the diameter, the better the fixation. And the longer the nail, the better the fixation, of course. Yeah. Thank you.
Thank you so much, Dr. Abdurrahman, for this interesting talk about interesting topic.
For giving me the chance. Thank you.
Thank you so much. Thank you so much. We have some questions. Dr. Ayman is asking about the privilege of titanium over stainless steel, I think.
Yeah, I think it's more related to the financial situation of if you have the option to use titanium, I think titanium is better than the stainless steel. Am I right?
Yes, of course. Yeah. Dr. Ali is asking about cam plates and external fixation for lower limb tolerate full weight bearing in day one post-operatively. This is according to the geometry of the
I think it depends on the type of fracture you are trying to fix.
I think we have no more questions. Thank you so much, Dr. Abdurrahman, for being with us.
Thank
you. Would you please, sir, stop your sharing screen?
Okay.
The last speaker will be my dear professor and my dear friend, Dr. Amr Azam. Professor Amr, you are with us?
Yes, Professor.
Professor
Thank
Amr,
you.
how are you, sir?
Yes,
Professor Amr will speak about a very, very important topic, which is bone morphogenic protein and tissue engineering. Thank you so much for being with us in this late time, sir. But you are asked to be at the last one.
Thank you for your flexibility and overcoming so much, my problems. Thank you very much, Dr. Ashraf. May I thank you for this very nice night. I think I enjoyed the last part of it very much. And may I start my presentation?
Please, sir.
Is it seen now?
It's starting to be shared. Yes, yes.
Okay.
Full screen, sir, please.
I think my presentation might be very simple, complementary to Dr. Abdurrahman Al-Komi. He was talking about his two professors. So I am going to use his two professors in my presentation. My name is Amr Azzam. I am working in the National Institute of Neuromotor System here in Cairo, Egypt. My presentation is about the bone morphogenetic protein and the tissue engineering. I am also an AO trauma Egypt Council, a community development officer. My institute is concerned about deformity correction, reconstruction, pediatric orthopedics, and we are having an accredited diploma for a pediatric orthopedics. The fourth batch has been graduated a few days ago. I have no potential conflicts of interest. So, may I have my slogan for this presentation is the healing bone has its natural biological intelligence. We are now talking a lot about the AI. So the creator, the holy creator, had the bone created with its own biological intelligence. So um, uh, learning objectives will be to identify the bone morphogenetic protein as a BMP and to evaluate the research and clinical data up to the last few years and to explore the key outcome for these publications and to understand the risks that may be faced while using these parts. So why this lecture is presented? Because we are having a problems with the healing and the bone fractures regarding the bone fractures and the segmental defects and also the devascularized fragments with the chronic non-union. My dear professors were talking about the start of this event, and the infection and osteomyelitis was a very important issue as well, with the cost and intraoperative time with the repeated operative interventions and the functional outcomes with the evidence-based medicine regarding the BMP-associated complications. So as Professor Abdurrahman was speaking about the biomechanically well-established implants a few minutes ago, but we are having a problem in such a cases that we may face a lot of cases of delayed and non-union and bone segment defects, in spite the high modalities of internal fixation used, either the intramedullary or surface fixation. So what about the complications? The complications for delayed union might be for 5 to 10%. Can you imagine that we are having every 10 cases you may face at the case of delayed or non-union? Might be, to be summarized, to be due to three elements: either a soft tissue trauma, or the intensity of this trauma, or a poor biomechanics of this homeostasis for the healing, and the last is the impaired biology. So our BMPs are particularly important in the cases of impaired biology of such a cases. What about the bone graft? The autologous bone graft to be taken, having a minor complications about 4 to 20% in a form of hematoma, seroma, or lateral cutaneous nervous thigh injury with a pain might last for 2 years post-operative, and also the female configuration or the female disfigurement that she may entangle. And also the major complications might present for 3 to 8% in the form of fractures on the iliac wing with a bleeding. What about this diamond? The diamond is very important here for the concept of bone healing. We keep talking about the growth factors. Growth factors are very important to help these cells to differentiate and maturate inside the scaffold and to be vascularized or helped by vascularization with the mechanical stability that Dr. Abdurrahman was talking about to achieve the union. So the growth factors are very important for all these parts of this diamond. So we are having three structures, either the osteoconductive, which is a passive process, helping the surface or the structure and promote in and on the growth of the cells, and also the osteoinductive, which is an active process, helped by what we are talking about today, the BMPs, bone morphogenic proteins, to stimulate the bone healing and recruit and differentiate the cells, which is a very important topic. And the osteogenic, the last one, is an active, and also it stimulates the bone healing and the materials containing a vital cells for bone formation, which is a very highly refined osteogenic materials and very difficult to get. What about the demineralized bone matrix as a source, the DBM for the bone morphogenic protein? The advantages are it's approved material all through the manuscripts until now. It's unlimited resources, but the disadvantages are the containment of BMPs might be variant, as the very low concentration and also the amount for this to be highly variable, and also the quality of the bone, donor bone, and the age. To what extent in the processing of the demineralized bone matrix we were controlled, we don't know till now. Does it simulate or stimulate the bone healing in the environment? In all environments that all the fractures might be helped, and this is variable as well. And also there is a risk of the lack of good clinical trial data for this bone demineralized matrix. What about the synthetic versus bone uses? So the bone composite is about 65% inorganic and 35% organic. But the tricalcium phosphate as a synthetic bone or the hydroxyapatite-based synthetic graft, it might stimulate or maybe substitute to resemble the combination or the composition of the normal bone. The tricalcium phosphates and hydroxyapatites might be helpful as a biocompatibility and no antigenicity, and produces our products should remodel like normal bone. We have to provide them to fill the gaps. A small hint about the RIA. The RIA started a few years ago, but it's reaming irrigation aspiration. It is an innovation during reaming of the intramedullary canal, like the second professor of the Dr. Abdurrahman was speaking about. Intramedullary nailing with this RIA irrigation aspiration, we can filter the irrigation aspiration products, and also we can reduce the pressure and the heat during reaming, and also clearance of the medullary canal, as well as the graft harvest. What about this RIA or reaming irrigation aspiration versus iliac graft? Small note about it, that it's having a comparable growth factor concentration and vital osteogenic cells, the very precious RIA irrigation aspiration products that may be used as an autograft. Going back to the composition of bone, this is about to be a 65% inorganic, and 35% organic. The 65 inorganic with hydroxyapatite with a 99% containment of bone calcium, of the body calcium. But the 35%, we can highlight now that the 35% of the organic part of the bone contain less than 0.01% of the growth factors, which is a very, very low percent. So the growth factors and cell differentiation, these growth factors might help in this process. This is our concern today. The mesenchymal cells differentiation and proliferation helped by the tissue growth factors that we are speaking about. What about tissue growth factors? A very famous tissue growth factor beta and bone morphogenic proteins. What are the famous types of bone morphogenic proteins? They are type 2, 4, and 7. And tissue growth factors beta, the famous 1 and 3. What about modeling and remodeling of bone? As Dr. Abdurrahman was speaking, we are going to pass rapidly. There is a continuous process between bone or osteoclastic activity and osteoclastic activity. So this is a continuous process all through the healing of the fractures for bone resorption and bone formation, for modeling and remodeling of these healing bones. What about the growth factors and cell differentiation? It is a very important to highlight that mesenchymal cells can be differentiated into, for the bones, into chondroplasts, helping the proliferation by growth factors into endochondral ossification in some situations. And mesenchymal cells also can differentiate into osteoplasts helped by the growth factors and also by growth factors proliferation into intramembranous ossifications in some other bones. Small words about the tissue or platelet-rich plasma. The platelet-rich plasma having advantages with it's autogenous and easily to be collected from blood and filtered with a centrifugation. But the disadvantages to be highlighted now, it is a low concentration of growth factors and lack of prospective clinical studies till now. Please be cautious. What about the BMPs? What we are concerned about today? We are having a great advantages of multiple experimental studies level type 1 clinical studies all through the years before, as good as or even better compared to the autogenous bone graft. What about the disadvantages? As we all know, this very high cost and some cases of reported antibody formation and reaction or swelling, and also the complication rate may be higher than the first reported because of the wide usage of these BMPs nowadays. What about the delivery system? We are having here a very nice paper published 2022 talking about the delivery system or the carriers. What about them? It might be the very famous one. We have the absorbable collagen sponge having the BMPs on this sponge, and also the bioceramic, which is a very innovative with a nanostructure technology, has improved the performance of the hydroxyapatite carrier of BMPs that are used nowadays. Hydrogels with the paste constituents that might be used in some cases of tibial plateau fractures, and synthetic polymer with 3D scaffolds. This has very nice updates till 2023, and the combination of between any two of the previously mentioned carriers, we can call it today is a complex combinations in the form of pellets, capsules, or the examples for delivery systems might be a nanostructure or nanotechnology to be used. What about the BMP clinical studies? It started years before, but we are illustrating today from 2004 to 2018, and with having a union rates ranging from 100% to 80% union. So it's the very, very good reputation for BMP usage. What about the BMP type 2? It's published about 2002, and the famous publication was about bone morphogenic protein type 7. It was 2001. Here we have some examples. One of the examples about BMP in an open fracture had been used for a delayed union of this fracture femur was fixed by intramedullary nail, and this is the tried on the human for the BMP insertion twice at 2 weeks with a volume of about 160 cc with a great union or the great success of healing. What about BMP7? It has a very nice rate of healing power augmentation. So it shows the same efficacy as BMP type 2 with might be used with autogenous bone graft or compared to autogenous bone graft in the first revision surgery. Also, it has a significant higher efficiency in osteoinduction as an active process we are speaking today about compared to autogenous bone graft in a multiple failed cases as well. What about the cost? It is a very costly elements. The recombinant BMP type 2 is about, and also recombinant BMP type 7 about to be $5,000 or more nowadays. But the FDA public health notification has a very important public notification for us. It is a life-threatening complications associated with recombinant human bone morphogenetic proteins in cervical spine fusion. It was published a few years ago, and they were highlighting some cases of oncogenic or oncological risks and nerve damages with a low rate. What about the complications of recombinant BMP2 for treating the complex tibial plateau fractures? And some cases with lack of experience, some cases had heterotropic ossification, as it was documented after using a BMP with a large volumes, and the surgeons must experience or have to exercise the cautions and weight the risk benefits for such cases and a proper amount to be used in the tibial plateau fracture. And we are evidencing that the demineralized bone matrix having a very good reputation and manuscript had supporting them, and to some extent bone morphogenetic protein type 7 with an infusion criteria, or to be infused in the criteria of type A. And lastly, to be mentioned is that the platelet-rich plasma blood concentrates. What about the combination? There is a very strong recommendation and evidence that BMP7 and the autograft together can be a better effect having in case of the atrophic non-union than either alone. This is a very important published 2023, I think, and 2018. So my take-home message will be that the BMPs aid in a cell differentiation, as well as it is an essential part of bone healing and proliferation of mesenchymal cells. So the recombinant BMP synthetic part may be a part of a strategy to provide osteoinduction in some cases, and BMP2 may aid in the treatment of open fractures as published in 2017, and the BMP7 might be beneficial for the treating atrophic non-union, especially that the patient have been operated on multiple times. Please beware about the complications arising from the BMP usage regarding the antigenicity, oncogenicity, or oncological effect, and this, local swelling. Please be aware about it. Thank you very much.
Thank you so much, Professor Amr Azam, for this interesting talk about an interesting future topic. I think by time it will be mandatory to know all the aspects regarding the bone morphogenic protein. Thank you so much, sir.
Thank you, Professor.
We have some questions for you, sir. The first question from Dr. Ali. Can we use soft and hard callus as bone graft for non-union fractures?
Soft and hard callus for non-union fractures. It's I didn't read anything about such a topic. How can we use a soft or hard callus in treating?
Sometimes I think if we have hypertrophic non-union, we can find callus. So sometimes you can use it as a graft.
Oh, thank you. Thank you. We are augmenting the hypertrophic non-union. That means that we have to augment the fixation. So we have to think about redo or augmenting the fixation to allow for the hypertrophic non-union to be a union. Thank you. Thank you.
Yes. Thank you so much, sir. The second question from Dr. Gamal Qasim. Can we use autologous bone graft concomitant with hydroxyapatite for acceleration of fracture healing?
Thank you for this. Is a very nice question. Thank you very much. We are using it nowadays because the the cost relative to the BMP usage, and it might be used in a pellets or capsules or powder somewhere, and it might be supplied like a paste. You may use it in some cases, but the BMPs are having a very high advantage for union or such a cases of in case of non-union or delayed union. Yes.
Yes, sir. The last question is about the bone marrow aspiration and injection in non-union or delayed union.
Yes, thank you. As we all know that the bone marrow aspiration is having a very, very complex technique, and we have to respect that is the publications or the manuscripts describing the technique, and you have to use the special instrument with a special core, and then you have to have the aspirate or aspirate until limited period or limited amount, after which you are going to not to get the recommended volume. So it has to be practiced and has to be you have to be trained about it, and you have to change the site of aspiration every now and then. So it is and may I finalize the comments about it? The aspirate here, it's not judged how many or how much the growth factors that you are getting from, or the mesenchymal cells that you may find in. So it is very well to be used, but in a very experienced surgeon.
Yes, sir. Thank you so much, sir. I think we have no more questions. Thank you so much, Dr. Amr Azam, for being solid with us. Thank you so much, sir.
Thank you, Professor. Thank you.
I think we come to the end, and I hope that we covered all the aspects for external and internal fixation, the basic principles, the biomaterials, the biomechanics. I think it's a good day. Many thanks to all the professors for sharing their experience with us in this very fruitful day. Many thanks to all attendees from all over the world. They are by hundreds, and many thanks to them for being with us. All the presentations are recorded, and it will be soon available on the Egyptian Orthopedic Association YouTube channel. See you after 1 month in the Spine Specialty Day with the Egyptian Spine Society. Thank you so much, sir. And
thank you, Prof, for this massive effort, really. A long time. Thanks so much. And thank Prof. Amr. Good night.
Thank you so much. Thank you. Have a nice time. Thank you so much.
شكرا يا باشا. شكرا.